My name is John Gillick. I'm the Assistant Professor of Neurological Surgery in the Division of Spinal Surgery in the Department of Neurosurgery at Rutgers, New Jersey Medical School, and I'll be presenting evaluation, indications, and techniques of revision spine surgery. My co-author is Dr. Robert Heery. I have no disclosures. Today's talk will discuss the initial evaluation of spinal revision surgery patients, talk about general surgical principles, postoperative spinal instability, deformity, pseudarthrosis, adjacent segment disease, and then how these principles apply to the cervical, lumbar, and thoracic spine. The initial evaluation of these patients, as with any patient, begins with a comprehensive history and examination. Special attention should be paid to any symptom-free period followed by recurrence, as this could indicate a recurrent herniation, for example, in lumbar disc herniations, as well as instrumentation failure. Prior operative reports should be obtained to determine what was done, what instrumentation had been used, as this could facilitate the revision surgery. AP and lateral x-rays can be obtained to rule out instability. A CT scan can be obtained to evaluate the fusion, rule out a pseudarthrosis, and also evaluate the extent of bony removal. An MRI can also be obtained to rule out any ongoing neural compression. In the setting of prior instrumentation, a CT myelogram may also be required. Good outcomes are achieved with careful patient selection and planning surgery on those with signs and symptoms that most clearly correlate with surgical pathology on imaging. The general surgical principles in these cases involves that normal anatomy should be exposed, and then further dissection can be carried out from normal to abnormal. This can be carried out in a rostral to caudal direction or a medial to lateral direction. CT image guidance can help the surgeon navigate through a distorted anatomy in the absence of normal anatomical landmarks. Special attention should be paid to the integrity of superficial tissues to reduce the risk of wound breakdown or infection. The risk of infection can also be mitigated with irrigation consisting of povidone iodine solution or the use of vancomycin powder directly in the wound. Postoperative instability and deformity can occur due to prior surgery, natural history of the primary process, or a combination of the two. It's most common in the C-spine due to the extensive motion in that region. Iatrogenic disruption of the posterior tension band, paraspinal muscles, and facet joint complexes may result in deformity development. Risk factors for destabilization include more than half of the medial facet or removal or young age. Patients may have symptoms caused by compression of neural elements by the deformity. In this particular case, the patient's undergone a prior cervical laminectomy and is now presenting with cervical kyphosis. This patient was treated in a circumferential fashion. Cases similar to these will be presented further. Pseudarthrosis is defined as the presence of symptomatic bony non-union more than 1 year after fusion surgery. It classically presents with initial improvement followed by development of progressive axial pain. The decision to treat is based on the severity of signs and symptoms coupled with radiographic evidence of non-union. Risk factors for pseudarthrosis include poor nutritional status, smoking or nicotine use, diabetes, rheumatoid arthritis, and the use of non-steroidal anti-inflammatory drugs or steroids. Non-union is most commonly observed at the occipital atlanto junction, the L5S1 level, and the site of the PSO. Postarthrodesis, adjacent segment degeneration and disease can occur craniocaudal to the fusion, and they're radiographically demonstrable in about 25% to 45% of patients. They can present as instability, spondylolisthesis, degenerative disc disease, facet hypertrophy, ligamentous hypertrophy, or osteophytic spurs. Fusion results in accelerated degeneration of the adjacent segments due to increased biomechanical stress. This particular case shows a 32-year-old woman who had undergone a T11S1 posterior fusion for degenerative scoliosis 2 years earlier. She complains of intractable middle and lower back pain and new onset bladder dysfunction. Imaging shows a proximal junctional kyphosis of 37 degrees above the fusion construct, a compression fracture at T10, and a thoracic scoliotic deformity. Pseudarthrosis at T11, T12 is demonstrated by the presence of halo-shaped radiolucencies surrounding the T11 pedicle screws. This is seen in figure C. The patient had a history of osteoporosis for which she was treated with recombinant human parathyroid hormone for 1 year before revision surgery. Postoperative anteroposterior and sagittal reconstructed CT scans are shown in sections D and E. After removal of the T11 pedicle screws, revision of the T11, T12 fusion, and internal reduction of the T10, T11 kyphoscoliotic deformity, a T5 through T12 posterior fusion was created and added on to the prior construct. In cervical spine revision, post-laminectomy kyphosis is one of the most commonly encountered pathologies. It's defined as a normal loss of kyphosis or anterior subluxation in the setting of prior laminectomy. A resection of greater than 50% of the facet joint complex is a strong risk factor. The risk is in the adult population is reported to be 5 to 50%. Age appears to be the most significant factor, and 90% incidence of kyphotic deformity is found in patients under 15 who underwent cervical or cervical thoracic laminectomy. Given the frequency of this complication, cervical laminoplasty or fusion is more commonly performed. Indications for reoperation in this setting include compression of the neural elements with myelopathy or radiculopathy, progressive or severe deformity, or axial mechanical pain. Techniques for correction include dorsal approach, ventral approach, or a combined approach. The dorsal approach in post-laminectomy kyphosis is used when the deformity is either completely or satisfactorily reducible with neck extension and the structural integrity of the ventral bony elements is maintained. One can intraoperatively reduce the kyphosis, whereby one surgeon puts the head in extension and the other directly visualizes the neural elements. Lateral mass and pedicle screws can be used with an emphasis on strong anchor points at the cranial and caudal ends of the construct. One can consider overbending the rod, but this can significantly preload the instrumentation, which may increase the risk of failure. A ventral approach is preferable in this setting when the deformity is either rigid or minimally reducible with neck extension and traction. Also used when ventral bony elements are structurally compromised. The spinal cord can sometimes be draped over this ventral kyphotic deformity, as demonstrated here in Figure A. Distraction with Gardner-Wells tongs and Caspar pins can be useful intraoperatively to reduce the kyphosis. We prefer multiple lordotic interbody cages as opposed to corpectomies. Based on the number of levels treated, a dorsal approach may also be required. In the ventral cervical technique, this is also preferred when there is graft extrusion, anterior neural compression, or symptomatic adjacent segment disease. The surgeon can remove fractured instrumentation, an extruded graft, or an artificial disc with this anterior approach. There's also less pain with the anterior approach. Scarring can make the approach more difficult in the setting of prior ventral surgery. Therefore, one may consider an ENT evaluation to determine if there is vocal cord paralysis. If both vocal cords are symmetric, one can simply proceed on the virgin side. In pseudoarthrosis encountered in the subaxial cervical spine, revision can usually be performed in a dorsal fashion. One must take care to preserve the posterior tension band, and it's important to have complete exposure and disrupt all articular surfaces that are to be fused. Larger rescue screws can be placed in previous screw holes to improve bony purchase. Poor bone quality may necessitate the use to extend to C2 and C7 to allow pars or pedicle screws, and autografts are always preferable in patients with an established history of pseudoarthrosis. At the occipitocervical junction, pseudoarthrosis can be quite challenging due to limited surface area available for fusion. C1, C2 articular surface can be particularly challenging during the exposure due to the presence of scar tissue. Local autograft can always be supplemented with allograft or additional remote autograft if needed, such as iliac crest bone graft. One can also consider fibular strut allograft, and postoperatively bracing with halo orthosis for at least 12 weeks provides optimal external immobilization. The atlanoaxial junction, the approach is similar to that of the OC junction. Meticulous decortication needs to be undertaken in order to expose all available bony surfaces. C1, C2 joint space can be packed with graft material after removal of cartilage. Structural and non-structural autografts are also preferable. If possible, a different construct should be used. If that's not an option, bone instrumentation interface should be completely cleared of all fibrous tissue in order to optimize the instrument bone interface. Options in this region include C1, C2 transarticular screws, C1 lateral mass screws with C2 pedicle or pars, or cross-translaminar screws, as well as interspinous or sublaminar wiring. If structural graft is used, it should be placed under axial compression to enhance bone healing. And in this setting, a halo is preferable, but a C-collar is also acceptable. Post-arthrodesis adjacent segment disease in the cervical spine can occur after anterior or posterior cervical fusion. For cases of compression or kyphosis at non-adjacent levels, a multi-level procedure is preferred to prevent adjacent level breakdown. In the absence of direct ventral compressive pathology, dorsal revision can be performed. The next topic to be discussed is lumbar spine revision. We'll start with segmental instability after posterior lumbar decompression. Dorsal decompression on lumbar spine is commonly used for lumbar stenosis, and iatrogenic instability can ensue due to loss of the posterior tension band. Risk factors include spondylolisthesis, preserved disc height, multi-level decompression, and the extent of pars and joint complex resection. Therefore, if greater than a half of the facet is resected, one can be at higher risk for iatrogenic instability. Patients can be effectively treated with dorsal decompression and fusion in this setting. Lateral and anterior approaches can also be considered. In the left figure, we have a patient that was treated posteriorly, and on the right, we have a patient that was treated in a hybrid mat model. She underwent 2-level XLIF followed by a posterior extension of her prior construct. The pseudarthrosis in the lumbar spine is also commonly encountered. The objective of lumbar pseudarthrosis revision is to optimize mechanical fixation and the environment for bone healing. The presence of neural compression may dictate the choice of approach for the surgeon. L4, L5, L5S1 can be favorable for a posterior approach. L4 and above, one can consider lateral. Unlike cervical and thoracic, circumferential fusion can be addressed from the posterior approach alone because one is able to get to the anterior third of the vertebral body from the posterior approach. Another commonly encountered recurrent pathology is recurrent lumbar disc herniation. It's most commonly defined as ipsilateral or contralateral disc reherniation at the same level as a prior surgery, causing symptoms after a minimum of 6 months symptom-free. It's been reported at a rate of 3% to 19% in open surgeries and 3.5% to 10.5% in minimally invasive surgeries. It's most common at the L4, L5 level, and this is thought to be due to the excessive motion at this level. Some authors advocate a limited discectomy without aggressive curettage, as this could potentially result in greater improvement in postoperative pain. The optimal study in working up these patients is an MRI with contrast. Scar tissue will homogeneously enhance, and a recurrent disc herniation will peripherally enhance, as demonstrated right here. The treatment of recurrent lumbar disc herniation is similar to that of a primary herniation in the absence of neurological deficit or instability. Our practice in revision discectomy is to perform a revision unless there is a second or third revision surgery, there is instability, there are severe degenerative changes, and or there is a chronic axial lumbar pain. Revision operation requires exposing normal anatomy above and below or lateral to the index level. One should dissect away from the epidural scar and the ligament inflavum in a normal to abnormal sequence. Lumbar adjacent segment disease can also be commonly encountered. It can be effectively treated from the posterior approach. If a simple decompression is chosen, this should be weighed against the risk of instability. If one's considering a non-instrumented fusion, one should note that the non-union rate is 80% of the setting of adjacent segment disease versus 17% when instrumentation is used. Addressing prior hardware can be facilitated by obtaining prior operative reports, as well as CT scans and x-rays. There are several surgical options available in addressing this pathology. One could partially expose the hardware and then just simply connect to the adjacent segment, to the prior construct. One can just remove and replace the existing construct, or one can remove and extend the construct, as is depicted here. Patient underwent a previous L3 to S1 fusion with adjacent segment disease at L2-3. Intraoperatively, solid fusion was noted from L3 to the sacrum, and the construct was simply extended up to L2-3. Thoracic spine revision is relatively infrequent due to the inherent rigidity and immobility of the thoracic spine. However, the cervicothoracic and thoracolumbar junctions are especially vulnerable to breakdown due to increased biomechanical stress. Most cases of thoracic pseudarthrosis are due to implant failure, sagittal imbalance, and improper hardware placement. Pseudarthrosis due to failure of bone implant interface can be addressed by extending the fusion construct. Ventral stabilization can be challenging, but approaches to consider are the transsternal, anterolateral, or costotransversectomy. Proximal junctional kyphosis, or PJK, is a well-recognized complication of posterior spinal segmental instrumentation following spinal deformity surgery. Proximal junctional failure is a distinct entity and is defined as PJK with neurological injury, structural compromise, increased need for correction, and possible worse clinical outcome. PJK is defined as a Cobb angle greater than or equal to 10 degrees increase in kyphosis between the upper instrumented vertebra and the UIV plus 2. Proximal junctional failure is PJK with a fracture of the UIV or UIV plus 1, posterior osteoligamentous disruption, or pull out of instrumentation at the UIV. Preventive strategies include cemented UIV plus 1 or plus 2, hybrid constructs consisting of pedicle screws and hooks, sublaminar bands, or interspinous ligament augmentation. The evaluation of these patients is done as previously described, with special attention focused to the clinical examination, constellation of symptoms, and in the context of radiographic findings. Cephalic construct extension is performed with kyphotic correction in patients with neurodeficit, myelopathy, deformity with instability, medically refractory pain, and/or disfiguring or abnormal posture. Depending on the flexibility of the deformity, the osteotomies are planned. These may be Smith-Peterson or pedicle subtraction osteotomies. In conclusion, revision operations present a unique set of challenges to the surgeon, as these procedures are often more difficult than the primary operation. The likelihood of a good outcome is decreased with each successive operation. Therefore, it is imperative that the clinical constellation of signs and symptoms are attributable to the pathology seen on imaging. Careful selection includes a detailed preoperative planning, sound understanding of spine biomechanics, and meticulous surgical techniques to ensure the best possible outcome. And these principles should be applied to the primary operations as well, in order to minimize the need for revision spinal surgery. Thank you.